So the key element, type-specific persistence, is that every high-risk type is significant if it is not cleared over time. And evaluating persistent requires type identification at an initial point in time. Pooled data does not differentiate between new infections and persistent ones, and identification of type makes sense not only to the patient but the practitioner. Now we're going to go on. I mean, we could talk about HPV a lot longer than anybody here probably wants to, but I want to talk about something else. Now, one of the key elements about utilizing liquid-based cytology is the ability to piggyback other tests on top of it. So with one one tissue collection, we can do a variety of molecular tests. And we have developed this STD6 pathogen panel looking at chlamydia, Neisseria gonorrhea, ureaplasma urolyticum, mycoplasma genitalium, mycoplasma hominis, and trichomonas vaginalis. These are important key organisms that we need to be aware of, and I'm going to just run through them quickly so you understand the significance of this. First of all, chlamydia. This is the most prevalent bacterial sexually transmitted infection. Chlamydial PID is the most important preventable cause of infertility and adverse pregnancy outcome there is out there. And the important element as we look at the continued chlamydial epidemic is the fact that most general practitioners and OBGYNs do not screen for chlamydia in the appropriate patient population. There are studies out there. 82% of pelvic exams by OBGYNs last year omitted appropriate chlamydia screen. We can treat chlamydia, but we have to recognize it. And the advantage of piggybacking this onto one thin prep sample is that all the physician has to do is check the box off and make it a standard policy that anyone between the ages of 20 and 45 should receive the benefit of a chlamydial screen. Now, Neisseria gonorrhea. Everyone knows about this, but the cost of gonorrhea in terms of the hospital costs of pelvic inflammatory disease, infertility, in vitro fertilization costs, these are enormous. So we obviously need to continue to screen for that. I want to spend a little bit of time talking about ureaplasma. This is the most common microorganism isolated from the uterus. It is associated with premature rupture of the membranes and premature labor. What happens with a ureaplasma infection is that a host of pro-inflammatory cytokines are released. IL-6 and proteinases are released. Those proteinases affect the mucus plug in the cervix. The mucus plug is an amazing anatomical structure that prevents the ascension of bacteria present in the vagina, lots of bacteria present in the vagina. It prevents the ascension of bacteria up into the uterus, which is a completely aseptic environment during pregnancy. What happens is these inflammatory agents break down the mucus plug, cause a breakdown in the membranes. You rupture membranes. You've ruptured your membranes at 24, 26 weeks, you bought yourself a trip to the hospital. I'm going to be rounding on you at the hospital twice a day until the baby is viable. We're going to try to get as much time as we can, but this is a huge cost. The problem is we can't diagnose ureaplasma in culture. Unless we use PCR technology, we don't even know it's there. This is a hugely unreported pathogen. Same thing is true for mycoplasma. Same things are operating here, and these contribute to a variety of other symptoms, including cervicitis and endometritis and fallopian tube dysfunction relating to infertility issues. Mycoplasma hominis, same thing. All of these organisms are contributing the same way, and all of them represent the same problem in terms of identifying them, either in culture, and they certainly cannot be identified with a stain. Trichomonas vaginalis. It's the most common sexually transmitted disease. 167 million cases worldwide annually, produces vaginitis. Vaginitis is a huge healthcare load in the primary care community. Contributes to premature labor, also doubles the increased risk of transmission of HIV when you have breakdown in the cervix. You have there's capillary bleeding as a result of the cervicitis, mixing of fluids, and a much greater risk of HIV transmission. So let's just talk. We're going to go quickly here to vaginitis. Now, vaginitis really refers to an inflammation of the vaginal wall caused by one or more of these infections. We have yeast infections caused by the Candidas. We also have bacterial vaginosis, B. fragilis, Gardnerella vaginale, and these major bacterial species that reduce the population of lactobacillus. And also, it can be caused by Trichomonas vaginalis. Now, let's talk a little bit about the joys, the absolute joys in my life of diagnosing bacterial vaginosis. You use Amsel's criteria. Amsel's criteria, you have to have 3 out of these 4. You need to have a thin, homogeneous white discharge. You need the presence of clue cells on microscopic examination, and you need a pH of 4.5. And also, we have the famous and ever popular whiff test, which involves the addition of KOH to the slide. This is a uniformly poorly done test in clinicians' offices and yields extremely variable results. And huge decisions are made on a day-to-day basis about whether people have this problem or not. I love this study. Throwing the dice for the diagnosis of vaginal complaints. It took 200 women. They had a group of general practitioners and gynecologists perform the Amsel test that I'm talking to you about before. These are patients with recurrent vaginal infections. They've been seen more than once in the doctor's office. They ultimately identified the organisms that were involved in those vaginal infections by PCR and by culture techniques. You can't see this, but let me explain. For bacterial vaginosis, the physicians were incorrect 61% of the time. They would be better off just flipping a coin. For Candida infections, they were wrong 77% of the time. And for mixed infections, which involved Candida and bacterial vaginosis, they were wrong 87% of the time. The bottom line is that without a molecular diagnostic technique, you're completely in the dark. You're not doing anything for your patient. You have absolutely no idea what you're doing. So the impact of STDs and vaginitis, reduced quality of life, reduced quality of sexual life. It has a huge burden on primary care resources. It increases HIV transmission, produces infertility, pregnancy loss, premature labor and delivery, and neonatal intensive care costs. The net result is an enormous emotional and economic price paid in suffering and allocation of healthcare resource. So we're going to talk about this more. What we are attempting to do is provide the clinician tools to do an adequate job for their patients. So I'll pass it off.
Hello, everybody. I would like to continue on STD testing.